right. Well, good morning, everyone. It's a privilege to introduce my friend and partner, Edwin Zishiri. I think most of you know Edwin. He joined our practice earlier this year, and he's already a favorite among my EP partners. I think most of my partners in general, and our nurses and advanced practice providers, and there's a good reason for that. Edwin is originally from Zimbabwe. That's where he did his medical school. He came to Boston in 2000 and spent 3.5 years at Harvard's School of Public Health doing research in immunology before joining Boston University to do his internal medicine residency. He then became a chief medical resident there before ultimately joining Cleveland Clinic for his cardiology and EP fellowship. He then went to practice in Michigan. He spent many years at Michigan Heart, which is a large group in Ann Arbor. And there he helped build and lead their complex ablation program. Edwin had multiple leadership roles also in Michigan Heart before joining our group. So he's a man with many talents, I can tell you that. I know he has a wealth of knowledge and he has passion for VT. So looking forward to learn a lot from Edwin. Edwin.
All right. Thank you. You're too kind in your introduction there. Thank you all for people that are in the audience and those that are watching online. So my task for today is to review an approach to ventricular arrhythmias, and my goal is going to be to try to keep everyone engaged. I know that the majority of people that are in the audience may not be electrophysiologists, but I hope that we can look at these things and learn something over the next 45 to 50 minutes. I hope to go over the presentation, and then hopefully we'll have some time for questions at the end. The EKG on the left is a gentleman that we saw last week. Actually, he had presented initially to one of our affiliated hospitals with palpitations and near syncope, and he was in this rapid wide complex tachycardia at 195 beats a minute. He required 2 cardioversions in the emergency room. He was referred here. I think Dr. Orlandi, others, and myself had taken care of this gentleman last week. This was an outflow tract ventricular tachycardia. He had ultimately some scarring on his MRI. Manju did an ablation for him on Friday, and Bill subsequently put a secondary prevention ICD for him on Saturday. On the left, your left, is one of my favorite devices. I like to do cardiac resynchronization therapy, not necessarily when there's a persistent left SVC without a right SVC, because it makes it challenging, but that's a nice picture right there. And I enjoy reading Mark Twain. So I have no conflicts of interest to disclose. And as I said, over the next 45 to 50 minutes or so, I hope to discuss some illustrative cases that showcase the issues, therapeutic options, some procedural and technical challenges and nuances for patients with some different flavors of ventricular arrhythmias. Some of my videos are unfortunately not playing well, but hopefully we're still going to be able to salvage the talk, and I'll show you some of the issues that we face when we do this. I'll talk about patients with frequent PVCs and non-sustained ventricular tachycardia in the presence of LV systolic dysfunction. I'll discuss some sustained monomorphic VT cases. I'll discuss some monomorphic VT in surgically corrected complex congenital heart disease patients. And as I said, I'll try to do my very best to stay out of the weeds and to keep it interesting for everyone and not just the EPs. But Raya, don't worry, there's going to be some cool stuff, hopefully, that you will find interesting as well. I'll show some epicardial cases for both PVCs and sustained VT. I will hopefully show an epicardial access in a patient who has prior open heart surgery, which is, challenging, I think, to do and not commonly done. I'll review some cases of idiopathic verapamil sensitive VT, and I'll discuss a case of polymorphic VT storm. So it's going to be rapid fire as we look at these cases, but I hope to showcase different flavors of ventricular arrhythmias that we take care of. And at the end, I'll discuss the most recent consensus expert guidelines and some of the primary data supporting what's in those guidelines. Okay. So the first case is a 60-year-old female. She had hypertension, hyperlipidemia, dilated non-ischemic cardiomyopathy with an ejection fraction of 20%. And she also had frequent unifocal premature ventricular contractions with PVC burden that was 47% on a recent Holter monitor. She had been seen by different cardiologists and a different group, and because she had been on good medical therapy with Carvedilol at the maximal dose and Entresto at the maximal dose, spironolactone for at least 12 months, and had also been initiated on Jardiance about 6 months prior, and her EF remained low. She had had, of course, angiography, MRIs, and the rest, and she had no scarring, and they'd recommended an ICD. So this is a baseline EKG. I just pulled out, almost a 12-lead rhythm strip from the tracings that we typically get in the EC in the lab, and you can see that, she's got sinus rhythm. She's got this left bundle branch morphology, predominantly inferior axis PVC with precordial QRS transition in V4, V5-ish. And as Holter had shown, on this strip, the PVC burden is about 50%. What should we do? Implant the ICD. She already has PVCs. Maybe she's at elevated risk of these ventricular arrhythmias, and we should go ahead and do that. We should obtain a CT angiogram and repeat the MRI, as it's been more than a year, and some of these things may have changed over time. Started on amiodarone or other antiarrhythmic therapy. Do something else. Show of hands, who's going to vote for 1? Nobody. 2? Nobody. 3? Some, good. Do something else. 4? Others, yes. So just because she had monofocal premature ventricular contractions, we felt, and she had no scarring on cardiac MRI, we felt that these PVCs were possibly responsible for LV systolic dysfunction. So we brought her to the EP lab. And in the EP world, something like 22 milliseconds, a 50th of a second can be very important. So we mapped this PVC to the free wall of the right ventricle. And you can see here, we come on ablation, which you come on right there. And it was 22 milliseconds pre-QRS, and then the PVCs go away, and they were forever silenced. In follow-up, and this is where it was kind of just above the tricuspid annulus in the 30-degree LAO position, about 12-ish o'clock, and 90 seconds of ablation, the PVC was never again seen. In follow-up, her ejection fraction came up to 55%. She no longer required an ICD, and she was one very happy patient. So there are PVCs that can cause LV systolic dysfunction. In general, when the PVC burden is more than 10,000 in 24 hours, about 10%, the higher that burden, the more likely that the PVCs can cause LV dysfunction, especially if they're monofocal. But nowadays, we can map, even if it's oligofocal, you can parallel map up to 8 PVCs, actually, with multi-electrode mapping and the mapping systems that we have. So it just depends on what you see on the Holter before you'd recommend that. But considering medical therapy, as Dave Hero had said, may also be an option, and sometimes we present that to the patient. But if they have a young patient, monofocal PVC, very good chance of getting a successful ablation procedure, we would recommend that. The second case I'm going to show is that of a 51-year-old female with hypertension, and she had highly symptomatic monofocal premature ventricular contractions that had occurred in a bigeminal fashion, and she presented for mapping and ablation of her PVCs. She had tried medical therapy with beta blockers and eventually sotalol, which was ineffective and resulted in fatigue. LVEF was also 40%, predominantly due to PVCs. And you can see that her PVCs were, right bundle morphology, inferior axis, and she had a lot of them over time. And this is an old EKG that I had found. I took care of her, I think, in 2017 or so, about 3 years after she had been diagnosed with this. They tried medical therapy and the rest of it. So we brought her to the EP lab, and this was how she presented. I always, all my partners in EP always do this too. We make sure that you put the precordial leads in the appropriate places, because sometimes It's not unusual that someone, say, has a left bundle morphology looking PVC on 12-lead EKG, and you bring them to the lab, and it looks different. Sometimes it's the exit size, sometimes it's the positioning of the electrodes that can differ. So we make sure in the EP lab that those are positioned appropriately, and then it makes it easier for us to map. So that was a PVC in the lab. We mapped it. It was about 13 milliseconds or so pre-QRS, and it was in the left ventricular outflow tract in the just in the left coronary cusp. So we can utilize. This is where my media file is not playing anymore. So you can get a basal short axis view of the left ventricular outflow tract. You see the left coronary cusp, which will be right here, the right coronary cusp, the non-coronary cusp. In real time, you can actually see where these are. You can see sometimes the left main coronary artery coming down here, the right coronary artery. And in this view, you can also see that the right ventricular outflow tract is very close to there. And sometimes this presents the challenge of deciding whether or not PVC or VT focus is in the right or left ventricular outflow tract. And sometimes it can break out on one side and you ablate on that side, and then you have to go on and do ablation on the contralateral side. I apologize, my media file is misbehaving here, but hopefully we'll get some of those to play. So this was in the left coronary cusp. So once you know which cusp you're in, and I use intracardiac echo for all these left ventricular outflow tract arrhythmias, because you can tell in real time really where you are. And you can draw with reasonable accuracy where the ostia of the coronary arteries are. And it's very important that you make sure that you're deep within the cusp, if it's possible, and away from the coronary ostia before you come on ablation. So in the short axis view, you determine which cusp you're close to. In the long axis view, which is where we do the ablation procedure, you make sure that you are deep within the cusp, and then you come on ablation. So this would be similar to what you would see. So you're deep in the cusp. The coronary artery will be coming from somewhere up there in the aortic sinus. And again, I apologize, my media files are misbehaving here. So again, that was 15 or so milliseconds pre-QRS. We came on ablation right there. And because I was close to the left main coronary artery, I used 25-watt ablation, and we did that for 60 seconds, and that PVC was gone. She felt great. She took herself off medical therapy at EF, and she was a happy patient. She just comes once a year for follow-up. So we see this. The third case is that of a 68-year-old female with a non-ischemic cardiomyopathy with an LVEF that was 35%. She also had very frequent PVCs. She had failed medical therapy with both Sorol and eventually amiodarone. And this was her PVC. So it was a right bundle morphology with a superior axis on the inferior leads, and it was transitioning to these RS complexes in V4, V5, suggestive of a focus in the posteromedial papillary muscle region. So again, intracardiac echo is key here. Again, my media files are not playing here. So you can see the posteromedial papillary muscle. You can see the two heads. Many times I try to get the catheter, if it's a posteromedial papillary muscle, between the two heads of the posteromedial papillary muscle right there. And you get a good ablation, sometimes 40 watts, sometimes for long periods of time, because these can be thick and they can arborize where the exit site comes out. And she did well as well from the base of the posteromedial papillary muscle and the LVEF mobilized. This one would have been very nice if my media images would play, but she is a 48-year-old female. She had sickle cell disease, hemoglobin SC. She had paroxysmal AF, a dilated non-ischemic cardiomyopathy, severe left ventricular systolic dysfunction, and had previously had a dual-chamber ICD, as well as PVCs, for which she had an attempted ablation at an outside institution in 2018. She was admitted with sustained monomorphic VT, resulting in ICD shocks, as well as PVCs with a morphology that was identical to the PVCs as well. So she presented for redo ablation procedure. So this was her PVC, and I can tell you that when you're mapping VT if you have a PVC that is identical to the VT morphology, it makes your life a lot easier. You don't have to deal with the hemodynamics sometimes that some of these patients with severe LV systolic dysfunction do experience, the hemodynamic compromise with sustained VT. So a monofocal PVC is even better for mapping and ablation. So you can tell it's a right bundle morphology. It's very wide. It's got this pseudo slurring in the intrinsicoid deflection and the pseudo delta, which is highly suggestive that this may be an epicardial focus. There's different criteria that have been published over the years to say that PVC focus or VT focus may be epicardial, a pseudo delta greater than 34 milliseconds, and intrinsicoid deflection greater than 85 milliseconds. The shortest RS complex is on the precordial greater than 121, and the maximum deflection index greater than 55, and QS or RS in lead 1. And if I go back to that 12 lead EKG, it meets essentially all those criteria. So she had failed an ablation procedure at an outside institution, and she was presenting for this. So we decided to go epicardial right off the bat. So just because on that EKG, it was highly suggestive that this was, basal anterolateral, and sometimes you can be very close to the origin of the circumflex or even the LAD. I tried to put in a coronary sinus catheter, and one that you can put in very deep, almost to the AIV region. Most of the times we go from the groin, of course, the femoral approach, but sometimes to seat the catheter deep in there, you have to go IJ. Let's see, is this going to play? I am sorry, guys. These were pretty good images. But over here, we're on the epicardial surface of the heart. You have the circumflex. You know what? Let me try this. I'm going to get out of this. I'm sorry, they were playing on my computer, and yeah, okay. You can see the circumflex is right there. And we had to, of course, you go in multiple orthogonal views to make sure that you're far away. And we were within 5 millimeters of the circumflex where the earliest site of activation was. We decided to come on ablation. Actually, we consulted with our interventional colleagues, which is one of the beauties of mapping some of these complex VTs, is that it's a team effort between multiple providers, and they were infusing saline or injecting saline while we did the ablation, and we came on ablation, and then it was successful, and she did well subsequently. There was actually a tiny marginal branch up here, which you could see prior to the ablation procedure, but after the ablation procedure, that marginal branch was no longer there and was sacrificed, but it was worth it for this specific patient. The second case is a lady I took care of in 2019. She's was a 37-year-old attorney, actually. She had frequent LV PVCs with some mild to moderate LV dysfunction. She had seen a few of my partners over the years. She had refused medical therapy, actually, because she was not really symptomatic. The PVCs were diagnosed when she was found to have an irregular heartbeat while trying to donate blood. One day while at work, she had a cardiac arrest. An AED, which was in her office, was luckily able to save her. And then when she presented to the ER, she was well. She had some chest soreness from the CPR she had received. Her physical exam was otherwise unremarkable. She had a long-standing history of these PVCs with the right bundle morphology, inferior axis. I think this EKG had been obtained in 2012, which is how long ago they diagnosed her with this. So she talked about her options, and she had a cardiac arrest. Should we look at her coronaries? Should we get a cardiac MRI? She'd had a couple of those in the past. Then implant an ICD. Should we do something else? Who's going to vote for 4 or 3? she had a cardiac arrest, so I had recommended that we pursue a PVC ablation and implant an ICD. She chose to go with just an ablation. She's an attorney, very bright woman, and she declined the ICD, actually. So we came on ablation. It was basal anterolateral LV. She wore a life vest for about 6 months. She had numerous Holters that showed no PVCs. The LVEF came up to 60%, and she declined our recommendation for an ICD. So, yes.
Did you induce anything before ablating her?
No, so she came in the PVCs. So typically we map. At the end of it all, of course, you always try to induce. I do ventricular stimulation. Sometimes we'll put them on isotope. No, we did not. And most of us don't typically try to induce anything because you're not trying to induce something, you don't have to shock her out of it. It may interfere with mapping her clinical arrhythmia, which was this PVC. So again, some of these PVCs can be benign. She was essentially an asymptomatic patient, incidentally diagnosed with this PVCs while trying to donate blood. She had refused medical therapy. She had some LV dysfunction from it, and she actually suffered a VF arrest from it, and she refused an ICD.
Does the morphology of the PVC affect your perception of how benign or not? You presented 4 or 5 PVCs,
yes.
And 2 or 3 of them
yes.
were a typical idiopathic or location, outflow tract, papillary muscle, or even if you have a fascicular one. The first one, which is an RV free wall,
yes.
And this one, which is an LV free wall, which is a classic location for non-ischemic cardiomyopathy origin PVC.
Right.
I just wonder, because for me, I wouldn't feel as good about this lady or the first one as I would have felt about the middle 3 ones where, so.
Yes, so that's a terrific question. So I think where the PVC is matters, but nowadays, with 3T MRIs and gadolinium enhancement and such, whether or not there's scarring also matters. I think how early coupled the PVC is may give you a sense as to how risky this PVC is. This lady had these PVCs dating before 2012. And typically when I see this PVC, it's not one that I would have necessarily said is higher risk for a VFRS, actually, but she actually experienced it. In the literature, the ones that come from the fascicles or the moderated band of the right ventricle, just because of the refractory period in those tissues, can be more early coupled, and they can more likely initiate VF. And I'll actually show a couple cases towards the end of that kind of PVC as well. So I know that it's not classic outflow, this one, but to be honest, I was surprised that she had experienced the VFRS with this specific PVC, but she did. And even the first one that I showed with the RV free wall, we tested her for ARVC. She had several MRIs, genetic testing, all the rest of it. She doesn't have it either.
They're not extremely sensitive sometimes.
Yes.
Out of all of them, which you did, this is the one where I would have not, I would have
right.
never assumed that she's going to be just fine, even with an improved EF, right?
Right.
But if she made that choice, that's a different story.
Right. We see a fair number of congenital patients here. So, and of course, because of the advances in open heart surgery and the care for these patients with complex congenital heart disease, many of them are living longer. And we in the adult EP and cardiology world are getting to see some of these patients. So he's a 40-year-old man. He had repaired tetralogy of Fallot. He had an enlarged right ventricle, pulmonic insufficiency, mild pulmonary hypertension, and it's a sustained monomorphic ventricular tachycardia that had been refractory to sorbitol and mexiletine and requiring ICD shocks. So he presented to the lab for mapping and ablation of his arrhythmia. His surgical history, which is very important in these congenital cases, because sometimes the scarring that creates the ventricular arrhythmia, or the arrhythmia, sometimes atrial arrhythmias too, is related to the previous surgical repair. Sometimes it's just related to the previous primary congenital heart defect. They were in the earlier stages. They had a Blalock-Taussig shunt at 4 months of age and had then they subsequently had a complete repair. At 5 years of age, they developed marked RV and RA enlargement and pulmonic stenosis with regurgitation and RV dysfunction, and required a third open heart surgery with reconstruction of the pulmonic valve, excision of the main PA, and insertion of pulmonic homograft. In 2012, they'd actually presented with sudden syncope without aura. An EP study had been performed, and they had inducible sustained monomorphic VT, and subsequently got an ICD. Over time, they'd received ICD shocks and were on sorbitol and mexilatine, hence they came in. This is a typical EKG for someone with previous congenital heart disease and the repairs that I described, and we brought them to the lab. It was pretty easy to induce ventricular tachycardia with double extra stimuli. It was a left bundle morphology, superior axis. And again, in corrected congenital heart disease, sometimes it's challenging, right? If you saw this in superior, you might think it was lower down in the right ventricle. But when we mapped it, and we typically like to do an activation map, and I also like to do entrainment mapping when it is possible, because that enables you to find where the critical isthmus is for these arrhythmias. So the cycle length was about 380 milliseconds. And, you know, I told you, Rayed and the other EPs, if they're online, that, you know, we would see some of this. So here we are trying to entrain, and you can tell here we're pacing at about 350 milliseconds, which is faster than the tachycardia cycle length. If you look here at the QRSs during pacing, here, they are pretty much identical to the QRSs during ventricular tachycardia. So you have concealed entrainment. If you measure the post-pacing interval from the last pace beat to the return electrogram right there, you would find that it's 490 milliseconds, which is about 50 milliseconds longer than the tachycardia cycle length. And, you know, we like to think about this. Are you in an inner loop, outer loop, et cetera? But for this specific case, just because you had concealed entrainment, the post-pacing interval was long, you know, you're in an adjacent bystander. So you're in a protected isthmus. That's why you can get concealed entrainment, but your post-pacing interval is normal. So if you ablated that site, you're not going to terminate the VT. So we like this better. So again, you've got concealed entrainment. Your post-pacing interval is identical to your tachycardia cycle length. And we look at the electrogram to the QRS, as well as the stimulus to the QRS, which was identical in about a third or less than a third of the tachycardia cycle length. And you know that you are, you know, close to the exit site of the isthmus right there. And if you come on ablation at that site, you know that it's going to be good. So we came on ablation. You see cycle length prolongation, and, you know, in about 3 seconds or so, the VT terminated. While this is good that you found the critical isthmus, there's a lot of data now that, you know, ablating the isthmus, terminating the VT, getting non-inducible VT is important, but it's also equally important to do what's called scar dechanneling and make sure that they don't have other VTs that can come. And I'll show you some of the data towards the end here. Again, sometimes these VTs are not hemodynamically tolerated. We have to pace map them, induce, pace terminate them, or sometimes cardiovert if they're not hemodynamically tolerated, despite sometimes we use mechanical circulatory support during these procedures. But nowadays we don't really need to, because you can map, and there's many surrogates of ablation that you can find without necessarily having the patient stay in sustained VT. And yeah, here you got a perfect pace map with the stimulus to QRS that was equal to the EGM to QRS as well. So that's a good site to ablate. So it was again in the outflow tract around, you know, where they'd done surgery with the patches and the repair, and you find the blue dots there were these complex fractionated electrograms, and we aim to ablate all those and perform dechanneling. And eventually they were non-inducible, which is what you like. The next case, I so wish that this would play, because in my view, this has been one of my favorite cases in EP. It's a 66-year-old man. He had an ischemic cardiomyopathy, ejection fraction 35%. He had a previous coronary artery bypass grafting with a Lima to the LAD, vein graft to the circumflex, previous ICD. multiple shocks despite escalating doses of solol and maxillatine. He had had 3 prior endocardial ablations at revered institutions, but he continued to have a VT. To make the story, he was actually allergic to amiodarone, and that wouldn't be started. So he came to the lab. This was in 2013, my second year of EP fellowship. And, he induced this VT, pretty easy to induce, double extra stimuli. The blood pressure was, 40 over pulp, not tolerated at all. And you can see this VT is, like those other epicardial VTs that I showed. It's got wide slurring without intrinsic weight deflection, highly suggestive that this is an epicardial focus. This is a patient who has had prior open heart surgery, 3 institutions with a lot of experience doing VT ablation, had attempted to do his ablation, and he was still having these. So his options would have included referral for possibly transplant and such. His VT was, of course, not hemodynamically tolerated, so you couldn't necessarily map it, but we chose to do something else. So we looked at this slide before, and if you look at his VT, it meets a lot of those. It's an epicardial VT for sure. So we decided, we consulted with our surgeons, with our interventional colleagues, that we were going to try to go epicardial in this patient who has had previous open heart surgery. On the epicardial surface of the heart, you've got a few things that you have to worry about. The coronary arteries, of course, well, as you map and before you do an ablation procedure, you have to be sure that you're far away from the coronary artery. And depending on where you are as well, sometimes you have to worry about the phrenic nerve. In this specific person, he doesn't have just normal coronary anatomy. He's got bypass grafts. I like to do the SOSA technique, where you go in with a 2E needle. It's essentially a soft spinal needle. It's not as sharp on the end. And you go in the subxiphoid space, and you advance the needle until you can actually feel the parietal pericardium, and you actually start feeling the heart beating. Once you feel that, you inject a little bit of contrast to make sure that you're in the pericardial space. And once you're sure that you're in the pericardial space, you advance. I typically advance a stiff wire, an Amplatz wire. And if someone has never had open heart surgery and they don't have adhesions in the pericardium, this wire that you see right here would typically go, you'll be able to see it in, this is an LAO projection. You'd see it go all the way out there on the left side of the heart and the right side of the heart, because you have free motion of that wire. In this specific patient, you can see from his previous open heart surgery, there was adhesions and maybe even some of the attachments of his bypass grafts. You only had access to, this part of the pericardium. But, let's see if this is going to play now. Maybe it will. No. I apologize. So we were on the epicardial surface of the heart. We mapped his native arteries, his bypass grafts, and we made sure that we stayed away from them. You can actually use a system called UniView on one of the mapping systems, and you can superimpose whatever fluoroscopy images that you have onto your map, and then you would know as well. So we were on the epicardial surface of the heart, and we were far away from the bypass grafts of the native arteries. Because his VT was hemodynamically untolerated, and this was the 4th attempt at VT, we actually ended up putting in an impeller support device so we could try to understand it better. Again, I apologize, my videos are not showing. So this was on the epicardial surface of the heart. You see some of these, mid-diastolic potentials. We tried entrainment, and you can see here that even though you can pace and accelerate the tachycardia to it, this was manifest entrainment in a lot of places that we had looked on the epicardial surface of the heart. But because his VT circuit was actually mid-myocardial, after ablation on the epicardial surface of the heart, where it was safe, and on the endocardial surface of the heart, we were eventually able to make him non-inducible. And he has done very well. Actually, I'm still kind of in touch with him, and he's doing well. He hasn't had any more VT, and He's been taken off the Solval and mexiletine and is now just on guideline-recommended medical therapy for his ischemic cardiomyopathy. So that was a very interesting case that I had a chance to participate in towards the tail end of my fellowship. So again, if you look at outcomes of ventricular tachycardia, making someone non-inducible is a good outcome. If they have inducible VT at the end, they're not going to do very well. They're going to have more VT shocks, come back to the hospital. If you make them non-inducible, but you don't perform late potential ablation, they do better than if they're still inducible. But the best outcome has been observed, and this has been in numerous trials that have been published and case series in those patients where you make them non-inducible and you look at these are the surrogates for reentry, which is late potential ablation or scar dechanneling, which you can do like here. So if you see this scar area, typically we map and you can see with a multi-electrode catheter that there's these late fractionated electrograms that are right there prior to scar dechanneling. After you've performed all these ablations, you remap, and even though you have some delay in those areas because there's slow conduction right there, you no longer have some of those sharper electrograms at the end, and that portends for a better outcome in the future. We don't always have to induce VT, especially nowadays, especially if it's scar-related VT, whether it's complex congenital heart disease, ischemic cardiomyopathies, even the infiltrative disorders such as sarcoid and such, depending on where the scar is. Nowadays, we can create these really rapid maps with multi-electrode mapping. We actually use software in the lab where we can actually define where some of the circuits may be coming from and where there's late potentials. In the past, you'd have to manually mark all those sites, but sometimes you can automate that. It's a good way to do it, but you always have to look at the data as you do the ablation procedure to figure out if it's accurate, and sometimes you have to remap and re-annotate things because the computer is only as good, or just like AI, is only as good as the data that you put into it. The next case I took care of was a 20-year-old basketball player. He had recurrent verapamil-sensitive VT. We see this occasionally. I think I have 3 cases actually in this practice over the last 8 or so months. His VT was suppressed by verapamil, but it impaired his athletic performance, so he wanted to pursue an ablation procedure. So this tends to be around the left posterior fascicle in the left ventricle. There's multi-electrode catheters, specifically linear decanav catheter, which is very good for mapping this arrhythmia because you can lay it on the septum, on that distal septum. You can see the Purkinje potentials, which you see here, P1, P2. We're doing entrainment right there. We're right on it. And then we come on ablation. The VT kind of accelerates, slows down, and then terminates, and it's kind of reentry right there. So he had a successful ablation procedure, was taken off the verapamil, and continued to do well with his college basketball career. This is one of the few VT cases that I've done on a Saturday afternoon or evening. So this gentleman had Waldenstrom's macroglobulinemia, non-Hodgkin's lymphoma. It was a B-cell lymphoma. His oncologist had just started him on ibrutinib, which is a bruton kinase inhibitor, and he was admitted with syncope. His initial EKG showed sinus rhythm with these frequent left bundle branch morphology, superior axis PVCs that are very early coupled. So if I see this, my heart is having some palpitations when this is happening. During the course of being in the ER, you see that those PVCs, just because it's an R&T phenomenon, you would repeatedly go into VF and be shocked, and then you go back into VF and be shocked. He had angiography, which was normal. His LVEF was about 15% by echo and LV-gram. He couldn't go to MRI just because he was so unstable. We tried atrial pacing and isopaternal, and he continued to have these arrhythmias. So he came in on a Friday night. We decided to take him, mobilize the EP lab and all the support that we needed to take him to the EP lab on a Saturday, late afternoon to the evening. And we mapped his PVC to the moderator band, actually, if you look at it. And we ablated it. Subsequently, his EF was fine. He had an MRI. He got a secondary prevention ICD anyway, because he had experienced this. And in the literature, apparently, ibrutinib or bruton kinase which is what is inhibited by the medication that had been put on, is variably expressed in cardiomyocytes, both in the atria and the ventricle. Most reports have talked about atrial fibrillation, some ventricular arrhythmias, but not quite like what this gentleman experienced. So the guidelines, the most recent guidelines on VT ablation were in 2019. We know many of the authors, and I'll show you the paper. I think the lead author was Ed Cronin, who was a fellow with us. I think he was in Jay's class. Jay was a year ahead of me in fellowship, and so we should participate in some of those efforts. So if someone has PVCs, it's very important to take a personal and family history to make sure that you're dealing with either a malignant event, which I've shown you, that some of these things can be really benign, but some of them can be really malignant. It's important to establish if the patient has structural heart disease or not. I focused my presentation on some of those patients that have had structural heart disease, that 10,000 per 24-hour mark. And again, everything in medicine, it's not always cut and dry, right? So if you have 9,500 in 24 hours, you could have LV dysfunction. You can have 50% and not have LV dysfunction. We don't understand, I don't understand why it's always like that. But if someone has no structural heart disease and the PVC burden is low, you can reassure the patient, though, sometimes it comes back and bites you. If they have structural heart disease, you should investigate why they have that. Medical therapy or ablation should be an option. The so-called non-sustained ventricular tachycardia in normal hearts, if you believe that exists. And I guess part of your question, Raed, was these traditional RVOT type. And we know now, especially with MRI imaging, that many patients that we thought had idiopathic right ventricular outflow tract VT may have, ARVC or some of these more malignant forms of heart disease. We know that sarcoidosis is a frequent malingerer, which can hide in there. So every time I see any one of these patients, before I say this is just an idiopathic outflow tract arrhythmia and put them on beta blockers, non-dihydropyridine calcium channel blocker, or recommend ablation depending on how the patient does or not, we do a comprehensive workup. And this is, again, highlights the importance of multidisciplinary teams. I think over my time here, the imaging team is phenomenal. Every time I walk in there, I talk to the guys about MRIs, Joao, Dr. Lesser, Dr. Lin, all of them. They've just been so responsive to us disturbing them and saying, oh, do you think this is okay or not, or whatever, so that we can make informed opinions for our patients. Sometimes you have to do exercise testing. That's how you're going to find some of these CPVT patients. Torsades de points, sometimes it's medications or electrolyte abnormalities. You have to stop them and such. In patients with structural heart disease, of course, you have to rule out acute coronary syndromes, which we know about. In the first 48 hours, usually you just make sure they adequately revascularize and treat with beta blockers. But if they're having these non-sustained runs of VT beyond 48 hours, depending on the clinical situation, we should consider an EP study for risk stratification. In my view, I don't think we do enough of these nowadays. I don't know what other folks think, but sometimes, you have a lot of these patients with LVEFs in the 35, 37, 40% range, and they have non-sustained VT. They don't meet criteria for a primary prevention ICD, but I think they need further risk stratification, some of those patients, and we need to do more of that. Of course, we see hypertrophic patients, and those need appropriate risk stratification, multimodality imaging, extended Holter testing. We have our fair share of genetic arrhythmia syndromes, Pukada, long and short QT syndromes, and early repolarization abnormality. And early repolarization syndrome is just one of those, the guidelines are not very good. We see a lot of patients with early repolarization on the EKG, and every time I see someone who has had syncope, I worry that could this be a ventricular arrhythmia. The vast majority of them end up being, the usual suspects, vasovagal syncope and such, but we don't have, in my view, a good way of risk stratifying those. Sustained monomorphic VT, of course, it is more serious. In general, a lot of those patients with structural heart disease, and now we're able to identify the structural heart disease a lot better with MRI and more detailed imaging. When an echo maybe perceived as normal, sometimes you find out about structural heart disease. And of course, if they do have that, you have to consider VT suppression, ICDs, medical therapy, and ablation. Polymorphic VT and VF, again, this is a challenging group. I showed you a case that we had to take to the EP lab almost emergently on a Saturday afternoon. Occasionally we see some of those cases. I think maybe a couple months ago, I think with a young lady who Bill has been taking care of, she gets these episodes of PVCs. She doesn't have a whole lot of PVCs, but they induce VF. She has a sub-QICD, has had numerous shocks, and I think Manju had the privilege of ablating PVC from the moderator band as well, is where it ended up being. I think I will, in the interest of time and to answer some questions, and again, I apologize, my videos were not working, and we'll try to, I guess, for the video that is going to be made for this presentation, make sure that I show a presentation where that works. I'll take some questions. Yes.
That was a very nice summary. Thank you, Edwin. And sort of to follow up on Raed's question, Douglas Mann was here and gave the virtual lecture, and he talked about LV dysfunction with recovered group ejection fraction. And so, when you see the ejection fraction become normal, what is he was taking the premise that these people really do have an underlying cardiomyopathy and they should be continued on their treatment, but it sounds like the practice is, what's your view on that?
It is also my view. That is typically what I would recommend to any patient that has LV dysfunction, regardless of what their arrhythmia is. We commonly in the EP world see patients with LV dysfunction from atrial arrhythmias, be it AFib with rapid rates or atrial flutter with rapid rates, and if those patients can tolerate guideline recommended medical therapy, we would recommend it. We would still treat the arrhythmias with the best available treatments, which in my view and the view of the data nowadays for those atrial arrhythmias is also ablation, especially in the presence of LV systolic dysfunction. But even if it normalizes, I'm not going to tell a patient that they should get off their guideline recommended medical therapy. I am not going to discharge the patient from the practice and say, if it's 60%, you don't need follow-up. You need to periodically check in with these people and make sure that they stay. But however, there are patients who come to the office and despite your best recommendation, they choose to go against it, and some of them do well. And I also think some of these purely electrical variants of cardiomyopathy may be different than the traditional so-called non-ischemic cardiomyopathy who doesn't have coronary disease, it's a normal MRI, no scarring on MRI, gets put on guideline recommended medical therapy, and the LVEF normalizes. Some of those patients may have genetic abnormalities that we haven't been able to identify just yet. And that may also be true for some of these pure electrical variants, right? Because not everybody with AFib with a rapid heart rate gets LV dysfunction. Not everybody with PVCs at 50% gets LV dysfunction. There must be something about the pathobiology of that specific patient that predisposes them to getting that dysfunction based on this electrical abnormality.
Yeah, I 100% agree. We invariably end up negotiating with these patients every single clinic visit, and sometimes we get them to see one of our advanced heart failure partners, especially many of them are very young, and I've been taught many times, I go to Chaska and Kasha goes to Chaska, and I know I wouldn't end up in a good place if I stopped a medicine without consulting with her. I learned very well that these patients should continue on medical therapy, but is it 4 of them or 5 of them when their EF is normal now when they're 35, or is it 2 of them? I don't know the answer, but they almost never end up being on the same amount of medicine that an otherwise 35-year-old with non-ischemic cardiomyopathy is. There's practical and there's guidelines, and I think we will learn a lot. We don't know everything, but I don't think we intentionally stop these medications.
Yeah, and cardiac resynchronization therapy is another one. We have patients, who have wide left bundle, female, no scar, etc. EF normalizers, they want to get off medications. Some of them do it, and they do fine. Some of them don't. So,
Well, I mean, there is a randomized trial that shows that beta blocker withdrawal is harmful. So you make the argument for at least the beta blocker. But you know, when you said that the electrophysiology mediated cardiomyopathies may be a little bit different, don't patients with AFib, with a tachycardia-mediated cardiomyopathy who have recovery of LV function after, rhythm control, have an increased risk of sudden death in the long term? So even though the EF is normalized, they're not.
well, I'm unaware of a study that has studied them, very, very long term to be able to say that. And again, it's not always a tachy-mediated myopathy. I see many patients where the EF may be read as, 43% or so, and they get multiple Holter after Holter, and their heart rates are actually well controlled. There's something about, in some patients, the irregularity of the ventricular activation that happens with AFib that can cause a cardiomyopathy even in the absence of tachycardia. So,
but the risk of sudden cardiac death in recovered LV function has been one of the most debated and least understood area in EP. That I can tell you, even with recent meetings about, with some of the device companies and research there and looking at huge databases from not only one study, but multiple, like patients who get an ICD and end up with recovered LV function, or by V, we see them all the time. And the argument is, even if you don't get therapy in the first 10 years, you still can get therapy after, and some of these have recovered their LV function. So in essence, you're right, and our approach is not that your AF recovered regardless to why and you're gonna be safe. But I don't know that we have solid data. I think this is an area where we should and can probably investigate more. That's at least, I don't know, Edwin, what's your feeling on that?
yeah, I agree. And the toughest is, by V, you put a by V ICD in someone, EF was 20, completely normal, you have to change it out later. They are scared of getting shocks. They're 75 now. They don't, it's not clear what exactly you should, whether you downgrade them to by V pacemaker, or you should still recommend a by V ICD, which is what I would do, because, for those things, it goes up, sometimes it comes down, and we don't have a good way of predicting what the risk is. Again, management of VT is an ultimate team sport. I think being in this team here, we collaborate with all the clinical cardiologists, imaging, advanced heart failure, structural intervention. I've been in VT cases where we had to, septal VT. We had to go in and get one of our interventional colleagues to find a septal perforator, inject alcohol. That's the way that you could get rid of that VT after ablating on the left septum, right septum, etc. And I think we are uniquely positioned to become one of the preeminent centers for management of ventricular arrhythmias going forward. So, yeah.
What do we know about the long-term outcome of the outflow tract PVC treatment? After you control it initially, 5-10 years.
Well, so I'm unaware of any long-term data, but again, for me, from a practical point of view, I think once I've done an ablation procedure for someone, they will always be linked to myself or the practice somehow. So we succeed initially, but sometimes some of them come back. So I think it's important to see them in follow-up, to get follow-up Holter monitors. Some of these diseases, like ARVC, sometimes the first time you see the patient, it's not apparent that that's what they have. 10 years down the line, they develop the other features, and then you see that this is what they have. So I always follow them. I mean, if they're doing really, really well, I say, well, follow up every 5 years or something like that, get a zero. If you get new symptoms or something like that, you follow up. But I never, quote unquote, tell them you're cured and you can go away and be yourself. So.
Agree, but do you agree, Edwin, that the vast majority of those who have truly monomorphic outflow tract PVCs, even if they have subtle MRI finding, there was a study that showed 70% of them can, which is, probably, we see MRI abnormalities in almost everyone now, but they do very well, right? I mean, so generally speaking, they do very well. I think if you have a pure outflow tract, a defined, whether it's a triggered activity, something that has been very well studied as an idiopathic mechanism, fascicular, which we know it's a re-entry because of a false tendon, outflow tract, which we know it's a triggered activity, a calcium overload. So if you target these purely electrical abnormality, I think most of them do very well long term. Edwin, you presented all the bad things about non-sustained VT and PVCs.
Right.
The truth is, every single monitor we read, every single pacemaker we interrogate
Right.
has non-sustained VT and PVCs. Sometimes I end up, if I go for 3 days without reading my pacemaker, signing on my pacemakers and reviewing them, there'll be 200 of them and there'll be 40 non-sustained VT.
Right.
So I think putting things in perspective, I'd love to hear from you on,
Right.
what should trigger you, because we see that everybody has, I'm joking obviously, have non-sustained VT and PVCs and coupled PVCs. So how do you put all that together for someone who's reading Zios or interrogating pacemakers? And
So I think we should not assume that PVCs or non-sustained VT is a benign entity until we have done a thorough and exhaustive evaluation of a patient. I think if you saw, non-sustained VT on the ZO, in my view, it is not unreasonable to have a telephone discussion with one of the EPs. I think we should get MRIs on a lot of these patients because they may have abnormalities that can affect what we do. And I think repeat and follow-up testing is warranted. So I know we see it a lot. Many times it's very benign. I presented a patient who had had PVCs for essentially a decade, and then she had a VF arrest. I worry about them, even though they are.
well, you know who to call if you have a question about non-sustained VT.
It's interesting that you mentioned that because I recently saw a patient who was referred for syncope.
Right.
And it was vaguely mediated, but they had gotten a Holter.
Yeah.
And she had brief non-sustained VT, one episode.
Right.
It was like 4 beats.
Right.
So I said, well, and a little bit unusual in a 40-year-old, 50-year-old with normal stress echo and everything. Let's get an MRI. She had myocarditis with edema.
Right.
But the thing is, I don't know how many times in the past we've sort of looked at a similar patient and said, well, it's 4 beats of non-sustained VT, it's probably nothing. I mean, it sounds like maybe an MRI in everybody, right?
That's what I would do.
Unless you have like ordinary disease and a prior MI, it seems like everybody could potentially harbor.
I think someone with non-sustained VT should get an MRI. Yeah, unless that's my.
We have 30 seconds left, and obviously everybody is right, but I would take the opposite of Dr. Zishiri, because you can't, just from a resource standpoint, right? I mean, we can't get an MRI on a patient with complete heart block and who's 40-year-old to make sure they have cardiac sarcoidosis to save our life. They're going 12 hours a day. So, and overall, this myocarditis, unless it's I don't know what it is, probably nothing. You probably didn't do anything more than giving them a beta blocker if it's just run of the mill.
Alcohol or exercise for
Right,
6 months.
right. So even if you didn't know, probably that patient would have done well. So it gets to a point where there is non-sustained VT and there's non-sustained VT. There's a 90-year-old and there's a 30-year-old with non-sustained VT. There's a very fast non-sustained VT and there is a 4 beats that are, So it shows you that this is not a clear science. Obviously, you have 2 electrophysiologists that have probably different take on non-sustained VT. Because
But I mean, if you look at epidemiologic studies, it's an increased risk of cardiac mortality. So we call
heart
it
heart rate variability does too, but we're not gonna get an MRI on everybody either. I mean, there's so much population studies that showed increased risk of so many things. In a population health world, it's just tough to do it this way. How long is non-sustained VT? Is it 4 beats? Is it 20 beats? Is it 24 seconds? Is it short coupled, long coupled? It's just a challenging thing. This is just challenging. I'm agreeing with Edwin that it's just a challenge. Every time we see it, we cringe, but I don't know. I wish we can do an MRI on everybody. We can do an echo on everybody.
Yeah, I know. But at least the ones I see, by the time they see me, I should make sure that, there's no craziness going on. I order MRI.